Our last section on perinatal infections is hepatitis B. Hepatitis B is a DNA virus. It is sexually transmitted. Now, the most common chronic viral hepatitis is hepatitis C. The most common. And yet, it has very little relevance in terms of obstetrics and perinatal transmission. There is no treatment that we use for hepatitis C in pregnancy. But in hepatitis B, there is things we can do. Let's look at our case. A 29-year-old multigravida was found on routine prenatal lab testing to be positive hepatitis B surface antigen. She's an ICU nurse. Perinatal infections, ICU nurse. She received 2 units of packed red blood cells 2 years ago after experiencing postpartum hemorrhage with her last pregnancy. Did she get it from her ICU patients? Did she get it from the packed red blood cells that she was transfused? Not entirely clear, but she is hepatitis B surface antigen positive. This map shows the areas of the world that have high prevalence of hepatitis B. And you can see northern Canada and Alaska among the Inuit, sub-Saharan Africa, Southeast and South Asia, high rates. Some years ago, I was visiting professor in China. And in the Chinese population, Rh negativity is only 1% of the population, compared with 15% in the United States. Hardly saw any Rh disease, but hepatitis B was rampant. It is endemic in Southeast Asia. This is a picture of a woman in a refugee camp in Laos who had hepatitis B, and she died a few weeks after this picture was taken. Very high rates in Southeast Asia. How is hepatitis B transmitted? Body fluids, similar to HIV, similar to CMV. The ways of hepatitis B transmission are similar to HIV and to CMV. IV drugs, sexual contact, perinatal. And our concern today is primarily perinatal. What are the symptoms of hepatitis B infection? Usually none. Most patients who have been exposed to hepatitis B will be carriers but will have no symptoms and no physical findings, and yet they are capable of transmitting this to their babies. The likelihood of transmission across the placenta is very low, and most of this is in the 3rd trimester. The greatest risk in terms of transmission from mom to baby is vaginal delivery, exposure of the fetus to the genital fluids in the birth canal. Yes, transplacental is possible, breast milk is possible, but primarily it is vaginal delivery. Now, looking at the number of patients who develop a chronic hepatitis and comparing adults and neonates, it is really tragic. 10% of adults will develop chronic hepatitis. 80% of newborns will develop chronic hepatitis. A high rate in the newborns, and totally unfair. The vertical transmission rate, if the mom is hepatitis B surface antigen positive only, it's 10%. But if she is hepatitis B surface antigen and E antigen, it's 80%, and the E antigen is an indicator of infectivity. So we want to check out and see if she's hepatitis B surface antigen positive, is she also E antigen positive? So we have a high rate of transmission if she is both surface antigen and E antigen positive. Now, the most likely outcome, if the mom has an acute infection, it is asymptomatic carrier, and yet she can transmit it to her baby at high rates. If the mom is hepatitis B surface antigen positive, the follow-up testing is hepatitis panel, and we're going to look for the other antigens. We're going to do liver enzymes, ALT, AST, gamma GT, look for bilirubin. If she has only surface antigen positive, if she has normal liver enzymes, and if she has a normal level of bilirubin, we will then say that she is an asymptomatic carrier, and yet she is capable of transmitting it to her sexual partners as well as to her baby. The delivery route. Well, my goodness, you'd say, since the baby gets this because of exposure to genital fluids, we should do a cesarean. No, a vaginal delivery. And the reason for this is because there is excellent ways of preventing the fetus from getting infected. Perinatal management, no scalp procedures. We do not use a scalp electrode in labor, no scalp IVs in the newborn, and all babies will get active immunization and passive immunization. The passive immunization is with hepatitis B immune globulin, H big. The active immunization will be given the first of 3 doses for the hepatitis vaccine. Management for acute hepatitis is not very good. Interferon, there are some new antivirals, but there's not a whole lot that we use in pregnancy. This is from the Center for Disease Control, and it shows since the advent of vaccination, the number of new cases of hepatitis B have dropped markedly in 20 years. Hepatitis B prevention by getting the 3 shots, and you should have received yours as a healthcare professional, and you need to make sure that you, in fact, have antibody positive. As far as the baby is concerned, at birth, it'll get the first of 3 doses of the hepatitis B vaccine, get the hepatitis B immune globulin. At 1 to 2 months of age, we'll get the 2nd dose, and at 6 months, we'll get the 3rd dose. Can I breastfeed my baby if I have hepatitis B? And the answer is yes. If your baby gets a shot called hepatitis B immune globulin and a shot of hepatitis B vaccine within 12 hours, it is okay for you to start breastfeeding your baby right away. Many HMOs now are vaccinating all babies, regardless of whether the mother is hepatitis B surface antigen positive or not. And I think that's a very cost-effective approach. In fact, many school districts are not allowing children to go past elementary school to enter into middle school without being immunized for hepatitis B. And in fact, this is the only sexually transmitted disease which can be prevented by immunization. There is now coming the Gardasil, which is the HPV, but that is not widely available yet. Hepatitis B is down among children and teens. According to the CDC, 90% drop. And that, I think, is great. All right, let's summarize what we have said before we end this section. These could be very helpful on your board exam. What should we know about group B beta strep? It is not lifelong immunity, neither is it lifelong latency, but it is lifelong colonization. Does not need to be treated in the mother. In labor, we will give Pen-G for prophylaxis to the baby and vaginal delivery. Toxoplasmosis and rubella are both lifelong immunity. Once the mother has IgG antibodies, she will never get a secondary infection unless she is immunosuppressed. The treatment for toxoplasmosis primary infection is pyrimethamine. There is no treatment for rubella and vaginal delivery. CMV, varicella, herpes virus, HIV, all have lifelong latency. Treatment for CMV, ganciclovir, vaginal delivery. Now, these really don't fit in terms of delivery. We don't do a cesarean for varicella, but for herpes virus, we will give acyclovir for treatment, and if there is an active lesion in the birth canal, cesarean delivery. For HIV, and this I think probably we need to change, we give triple therapy rather than AZT, and a cesarean is offered, particularly if she has a high viral load and a low CD4 count. In terms of the step 2 exam, what should be some terms you should remember in terms of these various infections? Toxoplasmosis, intracranial calcifications, chorioretinitis. Varicella, zigzag skin lesions. This is from early infection, first trimester, and microphthalmia, small eyes. Rubella, the most common finding, although it's very rare because we don't see rubella very much anymore, is deafness, congenital heart disease, and if we were to put a third one, it would be cataracts. CMV, remember, petechiae, hepatosplenomegaly. Syphilis, we have non-immune eye drops, macerated skin, and what is unique about herpes virus, HIV, and hepatitis B is there is no congenital syndrome with these infections at all. No syndrome at all. And that, ladies and gentlemen, is the end of hepatitis B and of our perinatal infections.